see 12, 13, 14, 15, 18, no, 20, 21, 22, 23, 24, 25, 26, 27. Oh, it means we have 54 holes. 54 holes distributed in 360 degrees. It means each hole will have a, I don't know, plus minus 6 degrees of rotation, okay? It means now we shift from the first to the sixth hole, 5 holes small, 5 or 6, 30 degrees of correction, okay? And we do the same here. We put the first hole here, distally, and the sixth hole on the proximal ring. This is only clinical view, or you may calculate it with a three-dimensional CT scan if you so precise. We use a CT scan for study of rotational deformity of the legs and the femur. We put another one here. Always display difference between two. This rod should be 6. If I put in 5, if I put it in the second hole, here I put in the 7. 7 minus 2, it is 5. Difference is 5 holes remain. Put here. Okay, another one again. Here the same, we put this in the second distally and in the 7 proximally. Okay, so like you see again, now my bolt connector hold, when I connect it with the bolt here, it is a corresponding or the position of the hip joint. And this connection bolt and the distal ring corresponding on the knee joint and this simulated external rotation of the femur. What we do now? Now I show you how we do this construction without pre-building. We do it step by step in the real life like we do in surgery. Okay, the first things, and I put this wire, okay, and always we respect the same principle like I said you before. When we need to do correction of rotation, your bone should be exactly on the center. Like this. Yeah. Like this. I'm afraid to break the femur. Okay, thank you, John. Okay. This wire should go exactly perpendicular to the bone. I adapt it to this position. Okay. Okay, again like this. Like this. Okay, oops, sorry. Okay. Put here. Okay, fix it. Another one here. Not. Okay, we put it in the center. Okay. Like this. Perfect. Now we'll do the tension, but before doing the tension, cut the tip, because professional trauma is dangerous. Somebody use it or something. Touch it. C'era qualcosa che si è incastrata. Okay, do the tension of the wire. We should do good tension, maximum. No. Yes, like this. One, two, three. Okay. Bend it this. No trauma. Okay. Okay, again we push shifting with this wire here. Now we prepare half pin. Maybe we position it. No, we have half pin we don't put here. Maybe no. We continue it. I think. No. Yeah, okay, we may put another wire. Easy. We do it differently a little bit. Remember that you should flex at the knee always when we do this job. Preferably this be wire going the not so crossed wire, because if not it will block the knee movement. Okay, we put like this. A little bit more distal. Then we do it in different plane. Ok, un second, like this, no? Scusa, lascia un pochino. Ok, like this. Okay, I'll show you only different way to fix it. Okay, one here. Here the bone, the wire touched the ring. We made, because it's a little bit oblique, I bend just a little bit wire for attach it more comfortable. We control the alignment. It should be like this. Okay. Put the wire here. And another part, you see it's so far from the ring. And here I use, okay, always maintain the center. I use the male post here. And the bolt. Okay, mexe. Não gira, não gira. Okay, use the wrenches. Okay, I tighten it. Do this. Okay. Okay, we do the tension of this wire. A little bit less than previous one because it is a male post. If you do too big tension, this post may be bended and the previous wire will lose the tension. Okay. And this is okay. Okay, like you see now there's two wires, crossed wires, just keep it much better than only one. It's difficult to displace. Okay, I do like this. And because I want to maintain the ring in the middle. Okay, nice. Okay, so good fixation, you see? It's not easy to displace it. Perfect. Aldo. Now what we do, I put the second wire in the way that it's not shifted, not slipping here. Now we build the proximal part of the tibia because of the femur. Because this second ring remain empty. We don't put any fixation element of this fragment because this ring we use only for correction of rotation. And we build a system now for correction of the varus deformity of the femur. What we do before putting this half pin in anything else, we build the frame between this proximal ring and 5 5 of 8 of the proximal part of the femur. And like you see here, we have a little bit, and now maybe we push and put in the better our frame, our femur, because our femur should be like this. Okay, fix it. Perfect. The majority of the deformity, we have it as a varus deformity, but not only varus, we have a little bit of recurvatum. What we build, in this case, we build the hinges by planar hinge. The hinge should be positioned at the level of the fracture or deformity, because if we design the deformity like we showed before, that the axis of distal femur is here, axis of proximal femur is here, and the axis of these two segments crossing exactly where we have a fracture. And this level, and the crossing these two lines, we should build the hinges. What we use here, I see that maybe the better way to put it, we put this 3 holes male. One, it will be lateral, okay, and should be built at the level of the external cortex of the femur. Like this. After that, we should connect them proximally. Maybe we put another one posterior, and this way we orient it better. Another one, 1, 2, 3, 4, 6, 3, 4, 6 here. Put the nut. Okay. Like this. Just a little bit disturb this frame. We put it just a little bit more proximal, like this. Okay, these two hinges should be realigned, one with another. Okay, what we do again? We put here the rod, corrective rod. We use maybe 100. We put the female here. Leave it. One. Prepare another one. Okay, what we do, we contain this hinge, what we put inside this rod on the ring. We need a space, not too much maybe, but we use this. Okay, and the important thing to remember that we should maintain this hinge, and the hinge we want to have it is in this level. Okay, what I do, I need one male. Today we have really difficult cases because all of them have a really big amount of deformity. Not easy to correct, but we are. Okay, bolt and nut. Okay, we put one washer, and this way the hinge works better. Okay. You see, we create biplanar hinge, because this hinge corrected varus deformity, but if we have a little bit of deformity in, like we said before, we have a little bit deformity in recurve atom, this hinge permits us to correct the deformity in recurve atom. Okay, like this. Now we build the same system posteriorly. Okay, we need the rod before. Okay, keep like this. Thank you. Because this proximal ring, this ring half of 8, it should be exactly perpendicular to the proximal femur with lateral view. Bolt and nut. There's another bolt and nut that is creating hinges for correction of varus. And I don't know if you will see in the lateral view, we have a little bit more distance on the posterior rod because it permits us to correct the recurve atom deformity. Oh, now it's much better and much stable this. Okay, and we realize now this 5/5 of 8 is perpendicular on proximal femur, and I look at in lateral view it's perpendicular, and now we use a cube. Okay, 2 holes cube, and we put the half pin in proximal femur. Don't have a space. Put one hole. We put one. Okay, like this, because if not, we need to displace again everything. Okay. Small bolt, again, short. Give me 5 millimeter half pin. Half millimeters, if possible.
6?
To 6, I think, yes. Okay, it's important things, control everything, perpendicularity of the frame to the bone. We do like this. Okay. Should fix it here. Control. Always control. To build this frame accurately. Okay. Perfect. Now it's much more stable system. What we do again, we continued to build in the frame here. Now, like you see, more important thing to construct the system for correction. It may be done in 2 ways. One, maybe position it medially, or if we want, we may do it the same way, creating the system for compression laterally. Last time we did it medially, and this time we do it laterally. How we do this? We may, again, to use a motor, particular motor that we used before. This one. Because it will be easy for us. What we do, we put the one knot, one bolt, like this. I put it plus minus in the middle or between these two rods. No, probably it will, because this motor, proximal part, we put in this fragment, because this is a fragment perpendicular to the axis of the bone. But the distal ring, the second ring, is not perpendicular of the axis of the fibula. In the distal part, we should create biplanar hinge. In this proximal, we have only monoplanar hinge here. And we use it here. We leave it in this position. What we need to do, we may use, or we use, we'll see now, because it's in any case should be biplanar, but we may use this with another rod inside. Okay, we always create something different. Like this. Yes, but we need to compress it. Better to have more space here. What we do this. And better again, maybe. If we do it upper again, 1 second. That's another thing maybe I do. I change here because we should calculate how much compression we should do. And I put it from the external side, and we save 1 centimeter of the space, like this. If you want to use this, we use it, again, like this. Not so.
Devi scivolare questo.
No, because we should create again the hinge, more hinge here, because it is monoplanar. Why we do it maybe in the classical way, like I like it. I do it like this because we need more space, and I do it in this way. Put like this. We put one whole post. I think it's okay or not. Yes, it should be. We put one washer only. Yes. And now we should put here the rod that permits to do compression and correction. Okay. We need not too long, exactly like this. Put the female here. This is more complicated part of this system. We'll do this inside. Because this system works in a shortening. Okay, we attach here. We put bolt and the nut. Yes, in this distal ring we have a biplanar hinge, because if you need to do any correction, we do it again. Okay, now we need to only to reinforce the system. For doing a little bit more easier, I disattach here the bone, and we attach our frame to this stuff here, like this. Okay, it will be quite the same position like we see before, but we attach the system to the ring. Okay, we maintain the proximal part of the femur in physiologic position, a little bit frontal version, like this. Okay, and now our aim only to reinforce the frame. We put this.
This is 1, 2, 3, 4, 6.
5. No? Yes, we do 1 oblique, 1 5. Okay, we do like this. Okay. Five millimeters. 5, Georgia. 5 millimeters. Yes. Not this 6 or 5, 6.
No, 5. This is 5. This is 6.
Oh yes. I don't see. Thank you. All right. You are right. Absolutely right. Okay. We put the half pin in the proximal part again. Okay. Thank you. Okay, we maintain the alignment. Good enough. Okay, we put another one, big tube, put here. Now we may put 6 if you want, and 5 again here. Okay, good stabilization. And the proximal part, we talked about this. Okay. No, don't want to go. Change. In any case, the quality of this metal is good, because usually they became, how to say, this is disposable things. Should be used only one time, but we use many times. Like you see, the quality of metal, the aluminum and the steel is good enough that we reuse it many times. Okay, now we fix the distal part. And here we put the cubes. I put the 1/2 pin lateral. bolt. Thank you. Go like this. Okay, fix it. This is one lateral half pin. Better is that we put another one, medial. We go there. Put the second or different. We put maybe the 3-hole like this. This depends of you. Here I put the wires below the half pin, but maybe in real life usually you put the half wire a little bit distal and half pin more proximal. But it depends of you how you want to do this. Okay, we are near of the finish of our construction now. Okay, cut the wire, bend the wire. This is a complicated frame in any case, not so easy. Okay, and what we do, we create the fracture, we release this plate, the last one. Okay, finished. You see the frame is stable enough, the fracture is no moves without our command, and now we need to command this frame to adjust all this deformity. How we do it? Like I explained you before, we may do it in this way. We release the hinges, this anterior hinge, release, posterior hinge, release. And what we do action with this rod in shortening. Okay. If you feel it is compressed, what is this? Sorry. Here there is interfragmentary screw. It's not honest. I didn't see it before. We miss it in fluoroscopy.
X-ray was not perfect.
No, because we removed the plate, but we didn't do fluoroscopic control. Right? Always control something. If something screw remain, dangerous. There's a long screw. Okay, and now we start again. I don't understand if it's really long one. No, because there is a half pin here. It has disturbed me. Somebody put the really long screw. Terrible. I see maybe down here. But the problem is don't go because it's. Yeah. Keep it like this. Okay. Really long screw. Che non ti sto schiacciando, ha ragione.
C'è una fatica da giro.
Sì, c'è una fatica, sì.
Sei fuori,
Sì, ormai è uscita, sì. Ok, really long screw. My God. Ooh. Okay, now it will be different. What we do, we continue compression here. And now without screw, you see what's happened. We have this rotation system, correction system. And we correct the varus, slowly. I need to see from above. Okay, this permits us to see how we do correction of varus. Okay, you see it. Perfect. Just a little bit of lengthening because my hinge is exactly on the border of the femur cortex, lateral cortex of the femur. And like you see now, we are practically correct at varus. What we have now, yes, if we look to the lateral view, we have a recurvatum. Yes? You see it? Yes. This recurvatum, it is not dangerous for us because what we do a little bit of distraction anteriorly. And compression posteriorly. Only one thing we should remember here. That this hinge was not positioned exactly at the level of the fracture. This is important thing that you see. Because this hinge not works in the same plane. What I do, I remove this, I put the rod, then maintain the distance. and I adjust this rod. What I do, I remove this, attach this. So in any case, I may remove practically all this motor because I don't need so big motor here. We don't use it more. And what I do only again the distraction anteriorly. And I do a little bit compression posteriorly.
Take away, take out.
Yes, we may remove the motor. We don't need it more. And you see now that we correct varus, we correct procurvatum. Okay. Yes, we may put now the simple rods, straight position, and here, maybe not straight, but we put another one. But it's only for don't losing time. Now it's a more important thing is how we correct the torsional deformity, because you see we are realign the axis, no more procurvatum, no more varus deformity, but we have a torsion. And what we do when the patient comes to you to control, and you see that they started bone formation here, we do this control and we change the position of the rod. What I do, like you see here, we have a difference of 5 hole. What I do in the clinic, I remove one, or I put another one, reserve rod. We don't have here one. 120.
Which size?
120.
20, there.
Well, in any case, I start to, if you find it, what I do, if you look at, I remove this rod. You may use fifth rod, another one, or to do it one by one. What I do, it was parallel like this. Now, what I do, I put this rod oblique way, like this. I change a hole. It was the difference for 4, 5 holes. Now I put it like this, a little bit oblique. Like this. Yes, I use it oppositely in the end of the rod. In this way, I should not control the length of the rod. It will be easy for me. And what I do again, I use another rod, and I put it near of the previous one, here. I change the hole, like you see here. The difference remain 4. I do like this. I do like this, okay? After that, what I do? I remove this one. I never tied the rod immediately because another rod stays straight again, and we should do the tie the rods all together at the end. Okay, I remove this. I put it here. I change. Important things, don't mistake here, because you should put it in a good position. If you look it from the above, they looks like a crossed rod. One do like this, and the posterior do in a different way. This is helpful to understand if you do it right or not. This rod rotated like this, and we produce internal rotation this way. Now we change in this way. We change it one by one, because in the clinic you can't do it too fast. Better to do it one time in a week, this procedure. Sometimes I do it one time, 2 holes, but it is a little bit dangerous. Since this hole may be big size of the rings, you may do it 2 holes one day, but usually the ring is small in the tibia, better to do it only one time in a week. After that, before losing the last one, you start tightening a little bit, because if not, the rings lose stability. You tighten it, and after that, you put another one, new, and remove the last one. This system, you don't need to do progressive correction, and you don't need to create this complicated system. It looks easy if you prefer it, because like in this situation, it's too big amount of correction, but normally you don't have so big amount of rotational deformity. Okay, you see, now we change the position. We realign a little bit the knee, but it's not finished. What we do now, we don't have too much time to do step by step, one time in a week. It will be 5 weeks. We should wait me to do it. We can't. And what we do now together, we change it completely in acute way, because we don't have a sciatic nerve here. We don't afraid about the complication. And what we do, we practically here, we change it all the position, slowly, one by one, and we put it in the same position. You see, here, 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 Okay, now for 1 second, I need one more. 1, 2, 3, 4, 5. Like you see here, sometimes like maybe we may adjust it again, the deformity, but like you see, there is a little bit of displacement. This displacement happened because we can't put it exactly in the perfect position. Another thing, if you find this kind of displacement, you may do again the correction here. For example, you may do like this, touch it, put it near. Or you may change the position of the hinge. But this is not happen in real life. Why it's not happen? Because normally we do it when there is a regenerated bone here in the middle. And the regenerate, just keep it together. I don't do it immediately. I do it when the regenerate is growing. And the regenerated bone keep the bone better realignment. In the rotational, the correction not produce so big amount of displacement. You see, it is displaced at maybe 5 millimeters, but just because we don't have any, any connection or soft tissue here. But usually soft tissue help us to keep it better. Okay? Now we do like this. In any case, we have all opportunity to change it how we want. We may adjust it if you want it to be adjusted perfectly. Because we may change again the position of this rod. Okay, like this. But you imagine we did a really important correction of the deformity with valgus recurvatum and torsion. And like I said before, this is displacement. We will not achieve it. It's only because our frame so stable and we don't have any soft tissue here. But the realignment will be achieved. Just like this, it's perfect. Okay? I'm finished this morning. Any questions again? Yes? Microphone, if you have microphone. I don't know.
Thank you. I would ask two questions. First question, which is better? Correct severe rotation deformity with angulation. Start with rotation or angulation. In the last session, if there is severe rotation and angulation,
Because it depends which one it is more important. In the previous case, he wants to show you the progressive correction and the majority of the deformity was rotation. We don't have angulation, translation. It was a good realignment of the bone, only rotation. Obviously, for this reason, we build the frame for rotation. If remains some residual deformity, you do it later. In this case, it was unuseful to do correction of rotation before. It was much more important deformity in varus. And we correct varus, and after that, you realize better which kind of rotation you have, and you do it residually. Practically, principle is you start with the major deformity, and after that you finish with the smaller deformity correction.
Okay, the second question, which is better? Change the bar rod angulation for rotational deformity, or they use the hinge? Because the previous...
yes. I think this system, this acute correction, it is better to use for a small amount of correction. Maybe if you have, I don't know, 15 degrees, 10 degrees of rotation, you would want to be perfect because the patient said, I see in the clinic my leg is straight, but I see my foot a little bit outside like this, external. I said, okay, now we'll see. And it's arrived maybe 10 degrees of rotation, you change two whole of these rods, and it's perfect. It will be in the end. It's better to use this acute system for the smaller amount correction. If it is really big in the beginning, the aim of your treatment to treat the rotation, put this progressive system.
Thank you.
The hinge we use here is uniplanar hinge.
No, this is biplanar hinge. The hinge at the level of the varus was biplanar. Yes?
Biplanar, yes.
Biplanar, because it permits us to correct varus, and after that, when we correct varus, you see it was a recurvatum.
Yes.
And I use distraction anteriorly and compression posteriorly. In this way, we correct procurvatum, because it was another hinge there.
This is what you call universal hinge.
Yes, universally, I call it a biplanar hinge.
Yes. It doesn't affect the stability.
No, you may build it by your hand. Okay. You use a female, male, you build it, but there is a universal in the set of the Medicali. They have it. They pre-build it.
So I see the middle ring. You didn't fix it to the bone. It's free without fixation.
Which one?
The middle ring. Second one, the middle one.
Second, this middle ring, it was empty ring. It is, we don't need to fix anything because it should move for rotational deformity correction. If you put the half pin something there, you block it everything at the level of rotation. We don't use it.
It's just for
Yes, it's only for guiding deformity correction.
rotational deformity always corrected the last one. Yani we start with angular deformity and put rotational deformity at the last.
Like I explained him before,
yes.
that it depends of amount of deformity.
Yes,
the major deformity, you start first. And the second, less important deformity, you do the last.
Sir, when we correct a rotational deformity by the method of transferring rods from one holes to holes, we not tighten the nuts until all the rods transferring to the next
No, no,
one.
no, you should do it one by one. You put one, don't tighten it too much, tighten it just a little bit, because if you lose all of them, it's displaces everything immediately. You lose one by one, and when you choose the last one, you should tighten previous 3 rows, because in 3 rows you may maintain the alignment. And after that you change the last one, and you tie it all together. Because you should pay attention, because you release all stuff, you have achieved displacement immediately. It is dangerous and painful for the patient. No, the patient may be not so like here, because in any case there is regenerated bones, the soft tissue keeps and the scars keeps better. But in any case, better to do it in this way, one by one, to change the role.
Excuse me, sir. Would you consider having a half pin on the second ring until you correct the varus and the anterior posterior angulation? Then when you start the correction of the rotational deformity, would you remove it?
This is absolutely possible. You may put one half pin in the middle, in the second ring. We call it an empty ring. We may put one half pin or other stuff, but you should remove it before the correction rotation. Or another trick we do, we put the cube,
Yes.
with maybe 2 holes cube. After that, disattach the cube,
You start
and
removing.
you do correctional rotation, and after that we finish, we reattach this half pin again. Yes, we change the 1 hole, like you change the rods, you change 1 hole of the cube
Yes.
with the half pin.
Yes, thank you.
And it's more stable.
Excuse me, sir. I'd
Yes?
like to sure about one point. We correct the varus, we restore alignment acutely in the session, immediately.
Varus?
Yes, he had angulation, the case.
No, angulation you do it slowly. I show you now acutely because we do it a workshop. But in the real life, you should do correction progressively. It will be maybe in 1 month, not immediately.
So we
Slowly,
correct
slowly. Yeah.
Then
Yeah, slowly correction of varus. When you achieve varus, you do a little bit of length and you create regenerated bone, maybe in 1 month, 1 month and a half. After that, you do control, you see the good regenerate, because you don't need to do it immediately, because if not, you achieve displacement. If there is a regenerated bone, like a rubber, it becomes just solid and plastic. You may modify it.
Okay.
If you do it so quickly, you achieve displacement, you cut the regenerated bone, nothing growing, and you wait, it will be like a pseudarthrosis malunion. Better to do it in the growing bone.
gradual correction of varus,
Yeah.
then rotation.
Rotation, maybe you start after you finish correction of varus or
Yes.
irregulatomy here, wait 3-4 weeks. If you do X-ray, there is a good regenerate, you do rotation. Because in this way, rotation is so powerful that the bone can resist of rotation.
Okay.
But it is not displaced. And you modify it, the regenerate becomes stronger.
Can we correct both slowly, the rotation and varus?
Both together.
Yes.
I don't think it is better, because like I explained before,
Yes.
biological is better to correct virus, create regenerate, and after
Yes.
to do rotation.
Thank you very much.
Only for show you the difference. Yes, that's it. Yes, you can use later, you